education side of learning. Listen, I have a 20-year-old. I've been taking her in college. She would rather call me like from the other room. I would like speak words. Oh, it makes me crazy. You can touch her. You can feel her radial pulse.
Can you change?
Yep. So if you take the SIM pad,
replace it. You want to know how start, right? Or you can you'll take any wall airways.
Thank you guys all for making the effort to be here and taking time out of your busy schedule. It's a Friday, the Friday before the biggest holiday of the year in my house, Halloween. My kids absolutely love it. So thank you guys. I was hoping some people would dress up in costumes, but that did not happen either. This day really is about celebrating being together. Obviously, it's been so long. We haven't had the opportunity to have many of these events recently, so please take the time, meet some new friends today, network, enjoy each other's company, ask a lot of questions, get to know new people, and hopefully walk away at the end of the day with some new knowledge to share, right? It's about improving outcomes. So I'm Shannon Schneider. I'm the client executive. I cover the Bronx, Manhattan, and the Hudson Valley. And we are happy to partner with Medgar Evers for this adventure. We got a whole team here from Medgar Evers helping out. It's led by Dr. Shirley Daniels. She's the Department of Nursing chair. Dr. Daniels? There you go. Thank you. We have Monica Dixon, who's in charge of the Simulation Center. Monica.
Here's Monica.
Monica.
Wave, Monica.
And Jeanette Turner. Where's Jeanette? She running around here crazy? So she's part of the Medgar Evers team that helped us pull this event off today.
Welcome, welcome, welcome. And hopefully you'll enjoy the day and you'll see some wonderful new initiatives, and we'll have a great day today. It's a pleasure for me to introduce one of the most wonderful people I've ever met in my life. This person has made a profound impact on me. She was my pediatric clinical instructor. She is a woman who helps everyone. No matter what race, creed, color, she is there for you. Maria Scaramazino is an RN with a master's in nursing. She is a pediatric nurse practitioner and the Associate Executive Director of Nursing Operations. She has been with Health and Hospitals since 2010 and recently completed her 38th year in nursing. She began her career at Boston Children's Hospital in pediatric hematology, oncology, and bone marrow transplantation. After completing 2 years at Boston Children's Hospital, she moved back to New York. Thank you for moving back to New York. And started a career at Long Island Jewish Medical Center, where she opened a 4-bed laminar airflow bone marrow transplant unit and trained the nursing staff in the care of bone marrow transplant patients. Years later, after working as an off-tour assistant director of nursing covering Long Island Jewish Medical Center and Schneider's Children's Hospital, she became the nurse director and administrator of emergency services. In the year of 2001, she was trained in advanced emergency management training, including MCI, weapons of mass destruction, and hospital emergency preparedness. She started at New York City Health and Hospitals Corporation Woodhull Medical Center in 2010 as the Director of Nursing for Emergency Services. During this time, she collaborated in breakthrough lean methodology and improved many emergency department related services, especially patient flow initiatives. For the past 5 years, she has been at New York Hospital's Bellevue Medical Center as the Associate Executive Director for Nursing Operations. She is proud to be part of such an academic medical center and they follow the public health system's mission of caring. In addition to working in the hospital setting, she has been teaching as an adjunct professor since 1994 in an associate degree nursing program. She received her BSN from Simmons College and her master's in nursing administration and pediatric nurse practitioner degrees at Adelphi University. It is my pleasure, it is my honor to welcome Maria Scaramuzino.
Anyway, welcome everyone. Really happy to be here today. I'm going to start with some just nursing trends. But I know we're joined here today by many different disciplines. You know, our colleagues in EMS, in SIM. When I heard the story, I never knew the story of their company, which I know I'm not going to take the thunder away from Shannon, because she's going to tell you about that. But it was really heartwarming, and to be here today with other nursing colleagues, EMS, fire department, professors, and simulation people, it is really my honor. So, you know, nursing goes back to being one of the earliest professions, and it really dates back to when Florence Nightingale was assisting during the Crimean War. Nursing continues to emerge as a profession. I remember, you know, I went to school like 38 years ago now, right? Frightening, okay? And then they were talking about changing the entry-level degree. They wanted to change it back then to a bachelor's of science in nursing. But, you know, we have to get people out there into the workforce, and it is perfectly appropriate to have associate degree programs and associate degree nurses. And I'm going to tell you, as a hospital administrator, there is no difference in the caliber of student, but you want everyone to go back to school and to continue in education. The nursing shortage is going to continue to rise, however. We don't have enough schools. We don't have enough professors, all right? Academia tends not to reimburse our professors as much as people that work in the hospital setting. So that's why it's hard to cultivate a whole group of educators, all right? But, you know, everybody needs to wake up and realize that our nursing students, our students in general, are our greatest resource. And we have to reimburse the people appropriately who teach these students so that we have, you know, a continuous circle of people coming out. Okay. So as technology changes, nurses need to gain more education. So this just goes back to more advanced degrees and really a push on becoming advanced practice nurses. My first rotation in nursing school was labor and delivery, okay? And they actually made an error. They thought we were seniors, and there was some miscommunication between the school and the hospital, and we were sent directly into a labor room. Well, I barely could do blood pressure, right? You know, you're like trying to hear yourself. You know, you're trying to listen, right? The doctor's like, I need a blood pressure, I need this, I need that. And then, you know, like floundering. And then I remember my instructor comes in and is like, okay, Maria, we have to put in a Foley now. I'm like, do what? I mean, okay, yeah, I did it in, you know, the lab like once, okay? And it wasn't like the sim labs that we have now that's more interactive, that the mannequins actually look real. They talk, they vomit, they give birth, they do all these things. So, you know, when I really reflected upon this, I said, wow, how lucky our students are today that you can practice in an environment that you feel safe, that you could stop a minute and say, wait a minute, Professor Scaramuzino, do I do this first or do that first? You don't want to do that with a real person lying there, right? And then a lot of times the people will be like, get that student out of my room, right? And you feel humiliated, okay? Miss Dixon, right? I taught with Miss Dixon. I think we gave her one Foley kit, one box of 4x4 gauzes, and maybe like one enteral feeding bottle for her lab. And she created this master sim lab out of nothing. The sim labs actually look like med-surg units, delivery rooms, emergency rooms, safe learning environment, like we said, and the student is able to apply their theoretical knowledge into that clinical experience before they get to the hospital setting. And you know, practice makes perfect. Doing things over and over again in a sim lab, even talking to a mannequin, right? Some of our students have never really even had, you know, conversations with patients. So all these things are really frightening. So it builds your confidence. It certainly hones in on your skills, and it teaches you to work as a team and to have good communication skills. So, and the sim lab really is that environment where these things, you can break down these barriers and everybody could work together, feel comfortable, challenge themselves, and work within a setting where they feel that they can succeed. Okay. And that's it.
I'm honored. I love this lady. People know I don't like too many people, but no. But Mia, I love her. Inclusive, diversity. That is who she is. That is her spirit. And I just love you.
I love you too.
Come on.
Today.
Oh, so sweet. A minute doesn't seem like a long time.
There's a lot of concentration going on here. I'm loving it.
So Mia alluded to this earlier. Who knows the history of Laerdal? Why are we even doing this?
I know it now. I know it now.
You want to share?
No.
No?
It's too much of a special story.
So the Laerdal family actually made toys back in Stavanger.
I'd like to introduce the panel, and just prior to that, I just want to also say thank you for coming, for attending this morning, and coming in. And I want to also thank everybody, the panel, of course, for coming, the faculty that's here, and of course the faculty from Medgar Evers. I just wanted really quickly, because I've probably driven them crazy for the last 4 months, and that includes the summer, by the way. I didn't stop. I think I was calling people that were international. So I made a lot of calls, so I do appreciate that. And I do have to thank one other person that's not on the list, and that's Nisha, because I've probably driven her crazy for the last 3 weeks.
Yeah.
And Nisha's the person from security, on parking and the vaccinations. So I have to thank her also. And she's still allowing me in the building. So we're in good shape. With that said, thank you very much, panel. I would like to introduce you. You see, I'm really not a public speaker. I did well in the course, though. From New York City Health and Hospitals, the New York City Health and Hospitals, the MMRP team. 2 people are going to be on the panel that are going to be up. It's going to be Kim Campbell-Taylor and Marlene Arford going to be joining us. But the other team members are also here, and that's Candace McLean, Lauren Williams, and Danielle Butler. From Columbia School of Nursing, Dr. Kelly Bryant. From Northwell Health Emergency Medical Services, Bernard Robertson. Bernard Robertson from Northwell Health. And of course, Dr.
You nervous.
Dr. Daniels. Dr. Daniels will be moderating. I'm sorry. I apologize. I've been doing like the mannequins. Give me the mannequins, give me the side, give me things. But Dr. Daniels will be moderating.
Welcome back, everyone. Welcome to our panel discussion. Feel free, like he said, to ask any question, but if you want to ask a question, if you can speak like I can where you don't need a microphone, fine. If you can't, we have a mic for you right up in the front. Okay? So this is about diversity and inclusion.
Good morning, everybody. Thank you so much for carving out time during your day for this panel discussion. Super excited to be here and share the stage with the wonderful panelists to my right. Thank you so much for that warm introduction to both Shannon and Michael and Laridol for having us here, and to Dr. Daniels for extending this invitation. My name is Kimberly Campbell-Taylor, and I'm the Director of Nursing Simulation at New York City Health and Hospitals. And I'm presenting the Maternal Mortality Reduction Program with Ms. Marlene Hartford. She is one of the 2 wonderful educators, nurse educators that we have on our team. So I wanted to first start with a little overview of what our team is and does. We're going to then share some metrics and some data that's really important to all of our communities in healthcare. And third, we're going to talk about how we incorporate diversity, equity, and inclusion into our programs. So really quickly, New York City Health and Hospitals is an extremely diverse medical system, both its patients and its employees. We actually see and take care of about 1.5 million New Yorkers in a year. We employ about 46,000 of those diverse employees. Out of that 46,000, 8,600 of them are RNs. And we actually have approximately 17,000 deliveries per year. So that's just a little history and a background about New York City Health and Hospitals. Our simulation program is really unique and novel, and I'll tell you how it emerged. In 2018, City Hall looked at some World Health Organization data. And in that data, they found that Black, Hispanic, marginalized communities had a disparity when it came to severe maternal mortality when you showcase those numbers with their white peers. And Marlene will actually take a deeper dive in that data in her part of this presentation today. When they looked at this data, they said, well, what are we going to do about it? The Maternal Mortality Reduction Program, which you will hear us reference often as MMRP, they have 5 arms to that program. One of the arms to the program is ours, which is Simulation, Education, and Training. Another arm to that program looked at, so how are we charting? What do charts look like? So another one handles the electronic medical record and doing chart reviews and how we're coding things. Another part to that program, which is a huge part, is the maternal medical homes. In these maternal medical homes, we take care of high-risk moms pre and post-pregnancy. We actually have an addition in our outpatient department where anyone that is seeking long-acting birth control have that available to them. As they rolled out this program, we wanted to say, so how are we going to do this? We actually have 11 acute care facilities, 23 outpatient facilities, and there's a lot of people in our system. So we wanted to devise a plan in which we actually educated and trained everyone that puts their hands on obstetrical patients and on obstetrical units. So that is actually done through in situ simulation. In situ simulation means doing and recreating that event where they work. So if that was in a labor and delivery suite, if that was in a labor delivery triage, if that was on a postpartum unit, we wanted to recreate that event so we can look at the processes and systems with these different teams. This happens on the backs of these 4 people that are here. It takes 2 nurse educators and 2 clinical managers that you met earlier that split those 11 facilities, and they carry out these in situ simulations that happen in these real work areas. These topics range from unresponsive birthing person, which comes into our system. It also covers, which we call OB-ACLS. It also covers postpartum hemorrhage, and it covers shoulder dystocia, and now we're rolling out hypertensive crisis in pregnancy. We also have virtual reality suite in which we're able to educate all of our healthcare providers and all of those different obstetrical emergencies that would take place on labor and delivery or postpartum. The other thing that's really unique about our program is that our program is really agile, right? It's probably hard to meet the needs of those people. We have about 1,100 of those providers that we need to train. So we have help from 2 OB physicians on our group that are simulation trained, and we actually have core teams that are embedded inside each of those facilities, and they all range in size. But the heaviest lift, of course, is with our maternal mortality reduction team. They have scheduled simulations, and those are planned and try to happen, but those who work in a hospital-based program or as a healthcare provider know that that's really difficult to happen. If the census is high, if the acuity is high, if they've had sick calls, it's really difficult to perform those simulation events. So we actually have people that are inside those facilities who can run them, but our team is very malleable. They wait around, they try to see if they can run a sim at a better time, and try to make sure that every team member gets a chance to run through the simulation at least one time. So now I just talked about the nuts and bolts of our team. I want to pass the baton to Marlene, and she will dive into some of that amazing data that is heart-wrenching for our communities and how we incorporate diversity and equity and inclusion inside those simulation events.
Thank you so much, Kimberly. I think they can hear me without the mic. So when our program started, we really had to create a path, like Kimberly said, and we really had to decide how we're going to do this, right? Because there was no other team like ours that we could have really, follow. So I remember Lauren being there from the start, Kimberly being the first person on the team to start, and then I joined, and then Candace and Danielle are fairly new to the program, but we really had to decide how we're going to roll DEI into our programs. And I'm just going to use a cheat sheet here. And I'm going to refer to some statistics from the Department of Health. So the statistics from 2016 to 2018 from the DOH actually shows that there has been an overall improvement in maternal mortality with the implementation of a multi-pronged approach. And this is good news. But what is troubling is that the disparities remain unchanged. And Black women in New York City are still 5 times more likely to die from complications surrounding childbirth than white non-Hispanic women. And what is even more alarming from this report is that in 46% of those pregnancy-related deaths, discrimination was identified as a probable or definite circumstance surrounding those deaths. And it also indicated that most of these deaths were preventable. So we acknowledge that we all have implicit bias. And I always say, we're no experts in implicit bias and diversity, equity, and inclusion, but we do have a profound passion for it. And we do want to help in any way that we can, and we do learn a lot. We listen to Dr. Kelly Bryan all the time. We reach out to her. But yeah, so we do appreciate the need to shift from recognition, just knowing that we all have implicit bias, to transformation with the goal of changing discriminatory behaviors and policies to achieve better outcomes for our Black birthing people. So to this end, our simulation-based education now illustrates diversity within simulation technology with the use of Black and brown mannequins for our scenarios. So Laerdal has really created an amazing, full-body, high-tech, high-fidelity brown mannequin for us for our program. So she's Simon, and she is by far the most popular and well-loved mannequin used in our program. Simon represents Black and brown communities and really can speak any language we want her to, right? Depending on who's driving it, with any accent, right? And can simulate very realistically both normal and difficult births, like shoulder dystocia that Kimberly mentioned earlier, or breech births, postpartum hemorrhage, and several other scenarios that we use in our program. So thank you, Laerdal, for your amazing creation. We also use brown birthing prompts with a simulated patient to meet our learning objectives and to provide opportunities where our multidisciplinary teams can really practice together with an implicit bias lens. So as simulation educators, we ensure that every simulated scenario is reviewed for underlying implicit bias and includes learning objectives that address racism and other related biases. Our debriefers are prepared to discuss the role of implicit bias in all of our courses, and the hope is that this collective commitment to address institutional and structural racism and other related biases that negatively affect patient care be understood and be an expected professional responsibility. Psychological safety is important for these crucial conversations, and so we pay particular attention to the establishment of a safe container during the pre-brief and debrief, in which learners can really take advantage of a safe, brave space to speak up, to make mistakes, and to fully engage in the simulation and debriefing to have these difficult but very meaningful conversations. So on behalf of the other team members present here today, Lauren, Candace, and Danielle, and of course Kimberly, who's always there, and we hope will always be there to support us. We are proud to be part of this amazing initiative on the journey to really improve maternal outcomes for Black and brown birthing people, and would love to join together to say thank you again, Medgar Evers, thank you, Laerdal, for giving us that opportunity to share our program highlights. And thank you, everyone.
I'm Assistant Dean of Clinical Affairs and Simulation, Associate Professor at Columbia University. So I'm going to switch gears and talk about a little bit of what we're doing in academia. So some of the initiatives that we're doing, the first one I'll focus on is the students. So after George Floyd incident, there was a big push to say, what are we doing about DEI? We need to implement more DEI initiatives into our curriculum. Because as you know, we don't really have a lot of it in our curriculum. We have little pieces here and there. People say they're doing it, but really, how are we doing it in a meaningful way? So through simulation, some of the things that we've incorporated, one, we have scenarios. I'm gonna start with the basics. First, we need to identify our own implicit bias. So we have a session where we just have, a lot of it is not even simulation. We talk about it. We have the students tell us stories. They do their own implicit bias test because in order to work on something, you gotta identify it. So we do the Harvard implicit bias test. We have a group discussion about the results. People share their stories. We talk about what are they seeing in clinical practice. And let me tell you, some of the stories are horrible what our students are seeing today as a student. And the hard part, the struggle with students, and I know I felt the same way, we see it, but we don't feel empowered to do anything about it because we're just a student. I can't speak up. I don't want to get in trouble. And even when students do speak up and tell their clinical instructor, there's this feeling of we're a guest in the hospital. We don't want to rock the boat. So a lot of times these things are being seen, they're done, and nothing's being done about it. So one of the major focuses we have is, what do you do about it? We have a whole session called Mitigating Implicit Bias. So when you see something, it's almost like the MTA, when you see something, do something, or say something, that's exactly what we do. So we empower the students by teaching them different techniques about, if you see someone, for example, one of the scenarios we use is someone who comes in with sickle cell, you probably all know the story, in pain, and they're called a drug-seeking patient. And nobody wants to give them the pain medicine because they think they have an addiction to drugs. So we have real-life scenarios that we put on. We either show a video, we can put them on live, or we can have discussions. So there's multiple ways that you can go about this. And we talk about, what do you do as the nurse, as a nursing student, when you see these things happening? How can you politely call out the person? How can you educate the person? How can you just interrupt the whole conversation so that you get somebody to think and say, maybe what I said was not correct and I should rethink that. So that's one of the most important things, is not only identifying and talking about it, but empowering students, what do we do about it? So that's some of the scenarios we do. We have one that's on a female nurse is in a room with, this we do with doctors. We do some interprofessional ones, where there's one discrimination because they're a female. We got one where the nurse goes in the room and she's a black nurse and the patient is a white patient who thinks the person's in there and housekeeping and just keeps on saying, you can empty my trash or do this. How do you deal with that when you're experiencing it from patients? We have one where someone comes in who's intoxicated, known as the frequent flyer that comes in every Saturday night, intoxicated, and actually has a medical condition and is ignored because they think he just needs to sleep it off. So we have a scenario on that. So we really take real life stories and bring them to life in simulation, and we teach them how to deal with those scenarios. So those are just some of the actual scenarios we do. But also, I have the advantage of having a beautiful simulation center. So I don't only use it for our students, and this is something I encourage other simulation centers. A lot of us are in very under-resourced, communities that have health disparities. They need us to come in and put on certain educational sessions. So I also give back to the community, which is a great role that I have within my role as dean. So we will have health fairs right in our community where we're identifying a lot of people with undiagnosed high blood pressure, high cholesterol, and we do a lot of health education right in our backyard. We open up our simulation center and we offer CPR, hands-only CPR training, and have even little kids coming in and doing CPR training. We open it up to community-based organizations to come in. We have a significant opioid overdose problem in our neighborhood. We're one of the highest rates right in the South Bronx, where people are dying every day from opioid overdose. We do Narcan training and bring people in the community to come in and give them Narcan kits along with the training. We also have a shortage of people of color going into nursing. So we open up our simulation and have high school pipeline programs where we invite high school students to come in, whether it's for just a 2-hour session, and we make it fun. We put them through a whole simulation. We let them play with a mannequin. I'm not gonna say it's another company, sorry. And we let them, they're not gonna hurt the mannequin, we let them go through a whole scenario, give them meds, and let them see what it is to play the role of a nurse, because what they see on television is not necessarily the role of a nurse. So we give them a little background on nursing, we make it fun, we play a little Kahoot game, we give out prizes, and you'll be surprised that that little 2-hour session opens people's mind to say, you know what, I never thought about nursing, but I think that's a great profession. And then that's just the short version. Then we have a whole summer program where we have students come in, started as 1 day a week, and we put them through different curriculums such as a day in the life of a nurse. We do open it up to other professions because although I'm biased to nursing, we expose them to other professions. We have them learn CPR. 1 day is just dedicated to CPR training. We have another class just on social determinants of health. And then we have them present their final project on week 6. So those are just, let me make sure I hit all of them. Narcan community service. And then I don't want to forget, you know, there's definitely some bias and stigma towards the LGBTQ community. So we actually, again, I'm not the expert in that field, so I team up with someone and we put on a whole session, and we have a panel discussion sort of like this, and we have transgender people from a certain facility that come and tell their story. There's nothing more impactful when people come and tell their story. They talk about how it is to walk in a facility and people at the front desk are rolling their eyes because they keep on using the wrong gender and refuse to call them by the correct name. So we kind of tried, you know, to really not just by talking about it, but make it more of an experiential learning experience for our students to really address DEI. So those are some of my examples. And I'm gonna pass it out.
I'm Bernard Robinson, Director of Emergency Medical Services for Northwell Health. I agree with everything they said. There's nothing else for me to say. They nailed it. But seriously, the maternal health, actually, believe it or not, it hits me. Mainly because a few years ago, it really came to light when Serena Williams went through an issue. And I'm married, right? I'm married for 24 years. And my wife used to always tell me, the doctors don't listen. They don't listen. They don't hear what I'm saying. And you know, it's like, well, what do? You look for a doctor like you know what I mean? A black doctor, black female doctor, whatever. But then when that same thing happened to Serena Williams, she almost died giving childbirth. And then I think not around that same time in a Brooklyn hospital, a young mother died because the doctors didn't listen to her giving birth. You know, to see this right now and what this team is doing is amazing. And one thing I always say when I talk about diversity, DEI, is who is on your leadership team? Who's on your team? Who is running these programs? Because you cannot help a community if no one from that community is on your planning team or on that committee or in that room making decisions. So to see this group of black women doing something like this that is going to change the health for black mothers is incredible, and something I've kind of almost, I want to say I've never seen, but you guys are onto something original, which it shouldn't be, but I'm glad that you're doing it, and you know, keep doing that, definitely. So I work with EMS, I'm a paramedic. I started as an EMT. I used to work for HHC. I started before the merger. If you don't know, FDNY, and they merged EMS into FDNY in '96. I left in '99, but the field. So I'm speaking more from, I guess, a leadership perspective. I'm not a nurse, but the field of diversity, DEI. EMS as an industry nationwide is 75% male, 85%, as the report I read, non-minority. So 85% white males makes up EMS as an industry, right? Now, you see in New York, we're a very diverse city. That's different, but a whole country. So one of the things I do is I'm on a national task force to address DEI in EMS as a whole. So there are, discussions about pipeline programs and things of that nature, youth programs, and kind of steer people that would not know about this kind of field of work. To be honest, I would not be in EMS. I would have known nothing about it if my father wasn't a lieutenant in EMS, who made me go into EMT school because I was just doing nothing after high school, and he wasn't having that. So I didn't want anything to do with EMS, to be honest. I didn't want to see blood. I didn't want to see none of that. I wanted to be a rapper, and it was the 90s. So I got into EMS, I got at the academy, and I fell in love with it right away. It was an amazing job, and working in the hospitals with the nurses. But you see that lack of diversity, and what it is, and I learned this later on. I grew up in Brooklyn, right? I'm from East Flatbush, Brooklyn. I may go work in an ambulance with somebody from Massapequa, Long Island, which I never heard of until I, started working with them. So they grew up in their silo, right? In their community. I grew up in my silo. You throw us in a truck together for 12 hours in another neighborhood where either only one of us is familiar with, or neither one of us is familiar with, you don't know the intricacies of how to, deal with that community. So there's a lot that we have to learn as far as cultural humility, right? Instead of building up that wall and turning your nose to something that you don't understand, how do you ask questions about it and learn more about it and tear down that wall that we all have built around us? Once we can start doing that, we'll make progress in other areas, right? You have to have leadership that understands this. Now, I told you the stats about EMS, right, as a whole. Now, imagine what the leadership stats are for that, right? So you gotta have leadership that understand this needs to be addressed. About students, so with Northwell, there's a medical school that's affiliated with Northwell at Hofstra University, and those medical students, their first year, they ride on our ambulances and become EMTs. The first year of medical school, at that school, you become an EMT and you ride on our ambulances and you get that firsthand patient experience. But what happens is those students also get feedback about their experience, and the things that they were reporting that they were seeing or hearing from our crews did not make my bosses very happy, but they were hearing what's going on, right? And it was spoken earlier about 2020 and what happened. So in 2020, I started a DEI committee for my agency. And that was born out of a couple of things. In 2020, we had COVID, right? Brand new, COVID was hardcore, right? Then we had Breonna Taylor, George Floyd, and Ahmaud Arbery back to back to back to back that summer, like 2 months span. So every day you're hearing the black community, black and brown community is dying the most from COVID, and what are we doing about it? Healthcare disparities. Then you see these 3 reports, and then you gotta go to work and be professional and work with somebody who is making comments that you don't wanna hear, or you don't agree on things, and that just builds that tension. How do you break that down? It's that communication. So we started that committee to kind of get our crew, our staff, our EMTs and medics to start having dialogues, and that's been very successful. Made some people nervous, which is understandable when you have all those different points of view, but exactly. And I said this before, those uncomfortable conversations are necessary. Yeah. And that's how we're gonna get to have, simulation mannequins that look like the population you're trying to treat, yes. Which is a novel concept, but probably way overdue, but huge, and groundbreaking in 2022. That's groundbreaking. But like I said, there's a lot of work to cover, but there's a lot of progress being made. So like forums like this are excellent. I didn't talk too much about Sims, sorry guys. The simulation's good too.
Okay. I didn't know you was finished. You didn't say I'm finished. I'm waiting. Okay. So questions from the audience.
I have a question. Yeah, so as we new nurses going into the world, so I want to have a question about what Dr. Kelly, one of the scenarios that Dr. Kelly Grimes talked about that you said you came in Columbia School of Nursing. So as a new nurse, new graduate nurse going into the world, so like you talked about the patients, some drug-seeking patients. So how do you identify the drug-seeking patient from the one that really needs the drug?
That's a
Good question. I say it's important to really talk to your patient. Even if you think somebody's drug seeking, why are we putting a negative stigma? If somebody has a problem with substance abuse, it's a disease, and we should treat it as such, just like diabetes or cancer. So I would say is just finding out more information, doing your screening. And if you do identify that the person may have a substance use disorder, then let's not ridicule them, let's not make them feel bad, let's not label them. We need to get away from labels. Drug seeking, I tell them, that should not be in your language, in your vocabulary. That person may have a disorder, and as a nurse, my responsibility is to try to see, are you interested in treatment? Referring them to places where they can seek treatment. What can I do to help this person? First, seeing where they're at. Maybe they're not ready for treatment, okay? And there's a whole philosophy on harm reduction. Not everybody's ready to stop. but what can I do to reduce their risk of dying? So it maybe today they're not ready to go to a drug rehab center, but maybe I can still talk to them about maybe reducing your drugs, or, you know, when you're ready, here are some resources for you, just hold on to it. You might not be ready today, or if you ever change your mind, I'm here for you. So I think we need to look at it from a more empathetic perspective versus just trying to put labels on people. So that would be my advice.
Thank you. Yeah, because the reason why I have the question was, sometime last week, I had a very similar story to what you just said. So we're having a discussion with someone, and the person is a nurse. So she was saying many years ago, something like that happened. The patient usually come in, so like just the drug seeking, like just talked about. So that patient has been coming from time to time to just come inside, come into the hospital, so and get the drug. So this time around, the nurse refused to give the patient the medication because they've been seeing him come in, get the drug, and then go. So the doctor said the nurse should give the medication. So the nurse refused. The nurse refused to give the medication, and the doctor had to give the medication himself. So, but unfortunately, few minutes after the doctor gave the medication, the patient coded and died.
So the patient really was sick.
Yes. So they had to like relieve the doctor. Yes. So they had to because they were saying that there was not enough assessment for them to like. So what I'm trying to ask is, that kind of nurse could have lost her job if she had given them medication. So thank God for this topic, and that's why I'm asking, as we new nurses, that we're not really proficient in our critical thinking skills, in our assessment skills. So like what we're supposed to do at that kind of situation.
I mean, it sounds like the patient had an underlying, so it wasn't that the doctor gave the meds and the patient died from what I'm taking. There was actually something wrong with the patient. So I think anybody coming in the door, that's again our bias. We think, oh, here she comes again, she just wants drugs, so we just don't even do an assessment. We just think that they're drug seeking, and then we miss the whole diagnosis, and this person died. So I think when people come through the door, we should still do our due diligence, still do our assessment, still take that history, because we can't assume when somebody comes in that, you know, they have this diagnosis. Because that leads to, that story that you just told has happened over and over and over again because of our own biases. And I don't work in a hospital, so I don't know if you want to say how you would address that.
Yeah, just really quickly, that is up, just as Dr. Bryant expressed, that happens often in healthcare, and deep in our memories is Nurse Vaught, who actually went to jail for a medication error. So Health and Hospitals is looking very closely at that, because we also don't want people to not disclose those errors and those missteps that happen in healthcare, because we all have to learn from them. I would say we actually have a nurse residency program that kind of supports that new nurse and new graduate for the first year of school, but this not simulation directly related, but really big on interprofessional communication for one, building that confidence and what clarity looks like with medication orders, communicating when you feel that something is a concern or that it's unsafe or a safety issue. Making sure you have the ability to speak up, and what goes hand in hand with speaking up is active listening. So we do use simulation to open up the forum to create that safe space so that we want to have people speak up to their healthcare team, but also be listened as an integral part of that healthcare team. When there's a misstep in healthcare, we do something that's called the root cause analysis, and they do a lot of fact finding to try to see what happened. We have just culture in place because we know that as healthcare providers, we have to have high regard for you. You came to work that morning or that evening to do the best job that you possibly could.
Hold on, calm down, calm down.
Yes, I wanted to find out, my name is Dr. Davis. I'm the Director of Clinical and Simulation at Long Island University. And yeah, I would love to have a conversation by sharing information, right? It's nice to share and network. And so I wanted to find out for the HHC group, what did you do different to change your data, your outcome? Did you incorporate the interdisciplinary teams? Because you know, it trickles down, right? You have to buy into, especially simulation. For me, I had to get the instructors and the staff to buy into it, like this is real. So you have to do hands-on inside simulation and then carry it out in the real world. It's the same thing when there's a code, right? You have to practice first in the simulation, and then when it happens, you're not going to say, well, I don't know what to do. You're going to track back and say, I learned this. So simulation is the same mindset and the same mind frame, but if we don't buy into it as a leadership, then it's going to trickle down to the student. Oh, this is not real anyway. Why are we going to simulation, right? So how were you able to change the outcome in your data to make it work for you?
So many things come up when you say those things. One is the stakeholder buy-in, right? Two, with leadership, is having them understand the why, right? Getting them to truly understand why this is important. Then we have a shared goal in all of this, and that shared goal is to give the best patient care that we can possible. As a faculty, it is lifelong learning, to know as much evidence-based practice about my role in this as possible. The other piece that's really important that we utilize in simulation to help get everybody on the same page, even with our leaders, is a pre-brief, right? We have rules of engagement for every sim and every encounter. And in those rules of engagement, as we're going to agree that we're going to treat this as real as possible. And that's in every event and in every moment. We're going to have to suspend our disbelief for a minute. And if that means, as a facilitator, that you might not agree with a particular scenario that we're delivering, even though we do this in an inclusive way, we have the whole group to come together in its development, that you know that the goal that we share is one goal, and our mission and our vision is super important to us, right? So all important with your leadership group. The other thing is, as we know, one time won't do it, right? American Heart Association says 90 days. If you don't use it, you lose it. I've downloaded an app maybe about 30 days ago, and I couldn't even go back into it because I totally forgot the steps to go back into. So it's that repeated effort. But I would say, even doing a needs assessment for your faculty, right? What are some of the challenges for doing this, right? I would really want to find out and dig a little bit deeper about what their blocks are to committing to a curriculum or an event. Asking them what are some of the challenges, how might they change it, having a shared agenda to talk about those things and how they might put their input on it. Maybe they don't agree with a part of it. Maybe they think it's not realistic enough. Maybe they think it's too much work, it takes too much time, but you won't know unless you ask them.
And I just want to add to that, showing value is really important. What's the value of these simulations, especially to the frontline, staff? And our simulation program really doesn't pull nurses out of the room and say, I'll train you, and pull physicians out of the room and say, no, we have them together, just like how they would actually perform in an emergency, together. So we get to hear the concerns, we get to learn from each other, talk with each other, just develop a better relationship. And then when the staff can actually see system and processes improving, that can help them do their job easier and more efficiently, they see value, they keep coming, they love it. So it's a journey, it's a process, but when you show that kind of value, it really helps.
And do you standardize patients in your? Yeah.
So we do, and it's just our team.
You're looking at them.
So you're looking at us.
Unfortunately, we don't have funds for a standardized patient program, so we train our own staff to play that patient or the family member for all of those different topics. Sometimes it can be exhausting. Things as tonic-clonic seizures are exhausting. With shoulder dystocia, for everyone in the room, we've said that word 3 times, and that is when the baby is awkwardly placed in the birthing canal and the shoulder is lodged behind the mom's larger bones and does not come out so easily. And that is a hard sim also to play because you're holding on to the baby to not let it come out as they're pulling. So I would say we do not have a standardized patient program. I know a lot of people do. We actually use our own staff for that.
You made me nervous. I was trying to figure out how one of you played the baby.
And then psychological safety is really important too. We make sure, that we pre-brief properly and just make sure people feel safe and take advantage of even a brave space to speak up, to even make mistakes, and then we talk about it and we learn from it. So.
And I just want to add 2 things as far as buy-in also, because I've been in this for 12 years. So I was in the beginning when people were like, that's a plastic mannequin, it's not me. I want to go back to the hospital. So I would say we have research now. So present them with the research articles that show when you practice mock codes, your mortality and morbidity goes down. Show them the data, show them the research is number 1, because we have it now after all these years. And number 2, if you're trying to get buy-in, get your C-suite, those important people, put on a simulation for them and bring them down to the simulation lab and let them see it, participate in it, because I can tell you that really gets them, because they don't understand. You can read about it, but until you're in the simulation and see, they'll have a greater appreciation for it. I call it my dog and pony show. One time I put on a whole subway derailment, and I had my SPs and a makeup artist come in every single station. I had bones coming out of ankles, facial lacerations, and I had the dean come in there, and she went through the whole scenario, and they were like, "You just gonna walk by and not help me?" Like, they were really engaging her. She was like, "Oh my goodness," And after that, she still talks about it to this day. So that would be my 2 pieces of advice if you're trying to get buy-in.
Yeah, for our program, we actually had the mayor come in and watch us and actually do a delivery. He actually did a birth himself, so it's really good. We have a deputy mayor also. So we go at the top.
Thank you. Some other hands were up? Dr. Holton?
Yeah, my hand was up, but I was afraid of the abuse.
She's used to it, don't worry.
But what I wanted to ask, I'm bringing it a little back to maternal mortality and morbidity and the implicit bias. And we know, even some of us, when we go to the doctor, for some reason, we're nurses, we're doctors, even ourselves, but we see the provider as almost the expert. When we know in actuality the patient, the client is the expert in their own care. Dr. Bryant, you mentioned doing community simulations. Have there been simulations about patient advocacy or the patient advocating for themselves? And what actual concrete techniques can we advise or instruct a patient, someone leaving here today, that they can go to their provider with? I can't change the mindset of my provider right now, but there are techniques I can probably do to get them to understand that I'm real, and what I'm saying is so, and I want to be heard. Are there any concrete techniques that you can leave us with that we can instruct our patients or the students?
So it's so funny because I do DEI work on the side. I'm actually working with a company right now on providing patient education on being an advocate for themselves. I just sent it 2 days ago, so it's fresh in my mind, particularly for Black women. So some of the tips, and again, as educators, we should be empowering our students to provide this education. If you're a practitioner, you should be telling your patients this. One of them is, as a patient, when you go to see that provider for the first time, it's an interview. You're interviewing them too. Okay? So going with your gut instinct. If it don't feel right, it's okay. You can find another provider. If you're talking about a complaint that you have and they're not listening to you, get a second opinion. Bring somebody with you during those visits. Make sure that you write your questions down and you have plenty of time when you're in there that your questions are being answered. To how to advocate for yourself. If you're saying, I'm telling you I'm having pain here, and you're not listening to me, I'm gonna tell you again. And if I'm not being heard, what are the next steps to escalate it? People don't know that. At that facility, is there, what do you guys call it, patient advocate or patient? Somebody that you can go to put a complaint in, patient experience, whoever that person is at that organization. To what questions to ask, to tell them that you're concerned, that I know the statistics, I'm a black woman, I know that I have a 3.3 times % chance of dying. What are you gonna do to ensure that I'm not one of those statistics? Having those real honest conversations with your provider, those are some of the tips. I'm trying to think of the other ones that we had in there. Being as educated as you can on your condition, whether it's pregnancy or whatever, knowing those dangerous signs and symptoms, being empowered yourself, so that you're not depending on the expert to let you know something's wrong. So those are some of the tips that we're putting in the patient education.
Oh, something else just came to mind. Carry a pen and paper, write down their names. Ask questions, write down, and they'll see also that you're serious in your care.
Absolutely.
And for the young people, even your note section of your phone, it's the favorite part of my phone, right? Just to write down, all of those details, right? Because they're super important. Just as Dr. Bryant said, the anxiety you feel when going to seek healthcare, it might be from another negative experience, it might be from a negative experience of a family member. And you sit down in front of a provider and they ask you a million questions and you've forgotten the questions that you had that were really important. So to piggyback with Dr. Bryant, to make sure that you are, and just as you stated, you're the expert of your own body. When something doesn't feel right, you have to make sure that you express it to that provider, which is really important. Really quickly with simulation though, we actually replay those events that we found there was a DOH article that highlighted the 3 top reasons and the 3 barriers to Black and brown communities doing birth. One was not being heard in that birthing space, even when things escalated. The other piece was them ignoring their birthing plan. So they came in with a birthing plan, but they found that Black, brown, and marginalized communities, they ignored them. They said, hey, let's go for a C-section, or this is what we're gonna do for you today. And the other one is not feeling a part of the care. So whatever the care plan for the day was, they didn't feel as if they had a choice or it's inclusive in that plan. So in our simulations, even if it does not come up and is reflected in that particular simulation, we make sure that we debrief and ask a question regarding that, just so that we get the team on board with thinking and realizing that these social determinants of health are impacting our patients, and how our patients are being seen, heard, or included are important in giving them a space to discuss that.
And also with regard to maternal health, we do have a doula service that can act as an advocate for the patient that we encourage people to take advantage of. So
we have one here as well.
Oh, nice.
Yes.
We're doing doula training for the students and people in the community.
And so we also have incorporated simulations as a part of that doula training.
And I think that's great because even in health and hospitals and most facilities, people are unsure of the role of a doula, right? Sometimes they're in this awkward position where the provider's not sure why they're there, if they actually have a significant other. The nurse might be ambivalent about their place and where do they belong. So I love that there's a training forum for them. And actually on our side, they actually do training for the providers also.
My final question, you just touched on something that I was really pondering on, in terms of how do you go about incorporating, or do you have a simulation program, either group, in terms of incorporating the multidisciplinary teams, like OT and pharmacy, and do you have that simulation, or are you running that simulation and reaching out to other departments? Because that's important too, right? Especially for these nursing students to see that.
So yes, all of our simulations are multidisciplinary. So we do sometimes do a one-off for nursing, of course, because just like someone shared, that's our baby. But our simulations include everything from clerical associates, hospital police, all the different providers, blood bank, nursing, pharmacy. And they're actually in that original core team. So when we talked about gathering stakeholders, those are the stakeholders that you also want to speak with. There's no way we would be able to take here a patient that has a postpartum hemorrhage in which that patient is bleeding a lot without incorporating and partnering with the blood bank. We did a number of SIMS and we realized the amount of time it actually takes to go to the blood bank. Some people were sending people that didn't know where the blood bank were. Sometimes it took 10 minutes on the elevator because it wouldn't allow you to go to the first floor. What did that look like? So we actually do incorporate multidisciplinary SIMS because we need the entire team to work through the process and systems of how to treat that patient and provide them with the best care.
I'll just do that. So
on our campus, we have an interprofessional group. So it consists of 2 students and a faculty from each department. OT, PT, dental, medicine, pastoral care, genetics, who am I missing? Public health, social work. So once a month, one of the schools hosts an event. So we did an IB escape room and it was amazing. So we had students from each of those disciplines work together and we came up with different clues. So one room, for example, was your patient doesn't have any teeth and you have to provide, this kind of diet. They're diabetic, they have diabetes, they have this, and we had all these foods on the table and they had to make a plate for them. Then we had one for, I think, OTPT, that she fell and she broke her leg and she has some internal fixation and she doesn't want to go to rehab, but she lives in a 6-story walk-up. And they had to talk to this SP and kind of use motivational interviewing to get them to go to rehab. And then there was another one that they just had to put an IV in. There's another one, so they were all different clues that included all the different disciplines, and we made interdisciplinary teams. So they had to work together to solve each clue, and once they solved it, they got the envelope to go to the next station, and whoever was first, we had a big party, and they celebrated and gave them gifts. So we do that once a year, and the students absolutely love it. But before that, not just the escape room, but we have an icebreaker in the beginning, where we ask certain questions and let them work together as groups. And let me tell you, we don't know about other professions. They were surprised to know that, OT and PT actually learn blood pressures and health assessment. I even learned a lot. So I love it because we're expected to work together in the hospital, but yet we learn in silos. And so that breaks down some of the silos. And I would say it takes a lot of work to put that escape room together, but the students appreciate it so much. And then they started having their little groups afterwards. They started exchanging, they got all this WhatsApp group and they meet up together. So I would highly recommend something like this fun for them to kind of.
I just want to make one comment, just to show you how simulation has grown and how advanced it has become. I just ran a sim in this last summer for Jay-Z and his entourage, right? He wasn't actually there. I was like, darn. But the whole overarching theme was COVID and life after, right? So they did a video. I was able to run the sim, which was, just to show how far technology has come into nursing and how even the entertainment business is incorporating sim and teamwork, right? And so I just wanted to share that, how amazing, and I have Laerdale, so I work with, so you guys are doing an amazing job, and, we are able to display the work of, the community and what is happening in the entertainment business.
Awesome. Thank you for sharing. So, just to be respectful of everybody's time, right? Everyone's getting hungry, so we'll break for lunch. We'll keep everybody on schedule. We'll go into the breakout groups right after lunch. So let me just, in your folders, again, is the agenda of which breakout sessions you picked. So for 12 o'clock, here are the different options. Moulage.
One more.
Yeah,